Good evening. I'm Dr. Alan Siegel. Welcome to Health IQ. Tonight we have a very special guest, Dr. Joseph Ho. He's a board-certified anesthesiologist and pain management specialist. Dr. Ho, welcome. Thanks for being here.
Thank you. Thank you for having me here. And I'm excited to talk about my specialty and what I do.
This is a great show tonight, and I'm excited to have you. Pain management is one of those things where people don't really know a lot about the specialty and what it is that you do. So give us some idea, what is pain management? What is it to be a pain management specialist?
Sure. So it's a relatively young specialty, so a lot of doctors, a lot of patients or people don't actually know exactly what a pain specialist does. I'm glad you asked the question. So in pain management, the physicians, as a medical specialty, the physicians are trained specifically to treat pain. Typically, the physicians gone to medical school, 4 years of residency, either in anesthesia, physiatry, neurology, and then put in some extra time after residency in doing a fellowship in pain management. The types of pain treated are different depending on each doctor's training as well as their comfort level.
Right. Well, there's one thing about pain that's interesting is that it's such a big problem in our country.
Right.
There's so much hospitalizations and so much treatment that goes into this, and it's a very costly thing that we deal with, from headaches to back pain to other types of chest pain is included in that. So what types of conditions do you treat normally? What would you see on a normal basis?
Sure. I see a variety of different pain conditions. I would say about 70–80% of my patients are coming to me because of spine problem. They have back pain, neck pain, sciatica, spinal stenosis. So that's just what's most common out there. I do see a variety of other pain conditions, patients with cancer pain, certain neuropathy, neuralgia, trigeminal neuralgia, headaches sometimes as well, cancer pain. So it really depends on each specialist training. Right?
So spine and spine-related pain is really at the top. And that makes sense because from the research I've seen, that is the most costly. It seems that for all of the medical expense usually relates back to the spine-related problems.
Right.
So which spine type of conditions are most prevalent? What causes the pain for most of these patients?
Right. I mean, nowadays Americans are living a lot longer. So certainly with that, there's a lot more time to accumulate spine problems like arthritis, herniated disc, spinal stenosis, sciatica symptoms. So I see those pretty commonly. And there are a variety of treatments options that are available. Typically many of these patients would reach out to their primary care physicians, course of oral steroids, anti-inflammatories, physical therapy may be used initially as a conservative treatment. Nowadays, Americans are more open-minded to alternative therapy, so acupuncture, chiropractors are also used as a first, second.
So you work with all of these different specialties as a kind of a team approach to help these patients.
Right.
But typically when someone's coming to see a pain management specialist, there's a more of a need for more, not necessarily invasive surgical procedures, but what I like to say minimally invasive or least invasive type of procedures to try and help the patient with their pain. So you mentioned some disc herniations and stenosis and other types of pain. So what type of procedural things would you do with as a pain management specialist? What things you might do in your office?
Right. We perform a lot of epidural steroid injections, a variety of nerve blocks, for arthritis and other pain conditions. Each patient, when they come, obviously we take a good history, we do a physical examination, review their medical records, MRIs, X-ray, CAT scan, and do our best to make a diagnosis and tailor the treatment to their plans. So the epidural steroid injection, I do consider them pretty minimal invasive because the procedures are just done under X-ray guidance, sometimes ultrasound guidance. The needles we use are often smaller size than even patients going for blood draw.
Right.
So, and the procedure could be done safely, effectively in just 5 minutes time, and it could provide pain relief, sometimes months or beyond for the patient.
And the injection consists of what are you actually injecting? Is it steroid? Is it lidocaine? Or is it a combination of all of those things?
Right. So it could be a combination. Usually there's a mixture of either some saline, some lidocaine, or a type of steroid. The saline just helps dilute the steroid solution so it will spread to a wider area. The lidocaine will numb the patient up as well as numb the area that we're trying to inject, providing some diagnostic value to our procedure, because if there are, let's say, 2 different areas that we're suspecting the patient having pain. The lidocaine, let's say we treat the first area and we inject some lidocaine there and the patient's pain gets better, we actually make the diagnosis that first area could be the cause of the pain.
Okay, so it's somewhat diagnostic.
Exactly,
at the same
with the
time
lidocaine.
It's some sort of relief or
Sure.
procedural.
So the steroid will serve as the therapeutic part of the procedure. We rely on the lidocaine for the first couple of hours to give us feedback on whether we have injected the correct area, and then the steroid will work a few days later, and hopefully last. The pain relief will last months at a time.
Yeah, the protocols seem to be, there's some limits to how many you can do in a certain area, because over time cortisone can degrade some tissue and degrade some bone, and you don't want to over flood the area that you're working on. At the same time, you can go maybe do 3 annually is typically about the rule of thumb, depending on.
Yeah, right. There are actually no hardcore number out there. You could. Some doctors are doing 1. Some doctors are doing 20. I don't advocate that many, but
it just depends on
depending the patient need as well as the effectiveness of the procedure, and sometimes, unfortunately, it's also dictated by the insurance as well.
Yeah, well, we know health insurance these days is a big hot topic. We're not going to talk about that all night because we'll be here forever, but that's something that sometimes the physician and the patient have to consider in their management of pain, which is also a big part of the whole issue. Because it seems such a prevalent part. So these conditions, are they genetic? Are they caused by trauma in most cases? What do you find are most of the causes of these things, or it's a combination of?
Right. There are times where patients are born with certain defects in their spine, and it could certainly affect and cause more pain down the road, when they're turn middle age, older. Majority of the time, the spine disorders are what we call degenerative, it's kind of wear and tear in a normal aging process. Certainly, trauma could accelerate a lot of issues. Patients that are doing a lot of physical labor are likely going to get hurt, cause a herniated disc in their back, their neck. Patients after car accidents as well are likely to get injured.
Car accidents. Well, a lot of times what I've seen in my experience is that sometimes a trauma or something has occurred in the past, and then 6 months, a year, several years later, symptoms start coming out. So people don't relate it back to that trauma. Kids that played football when they're younger had head trauma, car accidents that they just almost forgot about, but never had proper therapy, and then all of a sudden their hand's numb or their foot goes numb, and then I'm like, well, it could be related to that. You just didn't know you had it.
Exactly.
So the symptoms can come out later. So after an epidural, and you maybe work with other specialists, are there drugs or medications that you have to work with patients? I know sometimes, there's a lot of in the news about people getting hooked on certain types of pain medications. Right. How do you manage that in conjunction with the other therapies that you do?
Right. So we, take a good medical history from the patient, determine whether some of these medications are actually fitting for the patient. Certain types of pain condition, there are medications specifically for them. For example, their neuropathy, neuralgia, there are a line of seizure medicine or antidepressants are actually shown to be very effective treating neuropathy and neuralgia. Versus more mechanical pain, arthritis, joint pain, the anti-inflammatories may be much more helpful. Regarding the questions on the opiates, we are pretty strict about prescribing opiates. There are indications where there definitely could be used, such as patients with cancer pain. But for benign pain, for patients that are on the younger side, we're very hesitant about prescribing opiates.
And you try and keep the protocols shorter for people, just like
more for acute pain, right. The opiates often will help. Unfortunately, in the long term, patient often will develop tolerance, requiring escalating doses of this medication. And then the side effects could often become more of a problem.
Right. So you try and do the least amount as possible with the drugs in conjunction with the other therapies.
Right,
So
right.
another procedure that people I don't think are too familiar with is a neuromodulator, neurostimulator,
Right, right.
Spine stimulator. When would that be used? Well, what is that, and when would that be used? We have a little model here. Maybe you could show and explain
Yes.
what that's all about, and then we'll show a little video as well. So.
Right. So I actually think spinal cord stimulation is probably one of the best kept secret in pain management.
Yeah. And a lot of people don't know about it. So.
Right. So basically, it's a device similar to pacemakers. People with bad heart, they have arrhythmia, they have a pacemaker put in. It's a small battery with leads attached. And for the case of arrhythmia, the leads go into the heart and small electrical signals get sent to the heart and tell the heart to pace correctly. So similar things we could use for the spine. Patient coming with chronic back pain, sciatica pain, or even patient who have surgery, back surgery, who have failed surgery and continue to have pain, actually are good candidates for this procedure. So it's actually a two-stage procedure. The first stage, the patient actually come for a trial. We put temporary leads in, and the leads are about just this thick. And through the needles.
So those are actual wires that go. We're going to show a little video in a second, but that's those are wires that go into the spinal cord.
Not to the cord, but the outer layer of the spine. Right.
Okay.
And the patient actually leave. It's an outpatient procedure. It takes about an hour or two. Patient actually leave with the part of the leads actually inside their body, the other part outside.
Okay.
Everything is taped down. There's no incision involved, and there's a battery that the patient wear externally. There will be a belt they go home with. And the beauty of this
is this the battery here?
This is the size. You can see it, compared to my hand here.
Okay, it's pretty small.
It's pretty small, right? So the beauty really with this procedure, you get to do a test run.
Right.
You go home, you try for a few days.
Before it's permanent, it's like a test thing. Okay.
Exactly, and the patient come back and tell us whether it helps or not.
And there are settings where they can adjust it. There's actual modulations as part of the procedure, so they can turn it up or down.
Right. I mean, during the trial, because it's only a few days long, the programming is very simple. The patient has the ability to turn it on, turn it off using a remote. There's also setting in terms of how high or how low of a setting they want, and there could be some simple programming that are done so that different parts of the body may get stimulated depending on the position of the patient. Sometimes the patient, when they're sitting, they have pain in one area. When they're standing, they may have pain in a different area. And with the different programming, the patient has to control to determine what frequency, what setting, and so forth that the patient will need.
Well, let's show our viewers a little bit of a video. You can explain it a little bit while it's going on here. So you can see this actually gets implanted into the body eventually, right?
Right. So that would be a phase 2 when the patient did have a successful trial.
So this right here is where the stimulator would sit in the body?
Typically in just underneath the skin, underneath the fat layer of the skin, in the lower back upper buttock area.
All right, and then it basically blocks the pain signal. Is that how the mechanism of it?
Right, it's called neuromodulation, so it really changes how the spinal cord perceives pain. So
it tries to trick it almost?
In some way alters. Instead of pain, the patient actually would feel more tingling sensation in the area that the neuromodulation covers.
So they do have a different sensation. It almost replaces the pain with some other sensation to trick the body as to what's actually occurring.
So if you ask most patients with moderate severe pain, they could choose between pain versus a tingling sensation. I would say 99% of patients would say they would prefer the tingling over pain.
So that versus like a nerve block is really a different concept of trying to treat a condition. Because there are different, even with an epidural versus I'm sure nerve blocks, facet blocks. There's a lot of different types of treatments. So it really comes down to the diagnosis and what's causing the problem.
Correct. The nerve block, epidural, with the steroid shot. We could get months out of it. Sometimes we were very successful. We get years out of patients, and sometimes the patient are really just cured from the acute inflammation. But this, stays in the body and actually will work as long as the patient actually wants it to be turned on. Like I said, it's one of a few procedures out there.
A year, several years.
It's good for the battery right now are good for about 10 years, depending on how you use it, how frequently you use it, and it's a rechargeable one. So patient
Solar powered.
And every week, every other week, we'll could sit right next to, and now, like, they could be sitting in a chair watching TV and just charge it externally. And the battery is good for 10 years at least. And the replacement is simple. Just takes the battery out. There's nothing that needs to be done, and replace it with a new one just underneath the skin.
You mentioned before, you did say something that was interesting. You said failed back syndrome or failed back surgery, and there's kind of a misconception of, or misunderstanding when someone needs spinal surgery potentially, when they need a pain management specialist, when they need conservative care. How do you work with patients, or what do you tell patients maybe before they see a neurosurgeon, orthopedic, or how do you work with neurosurgeons, orthopedics to try and really help that patient either before they have surgery, after they have surgery? We don't like the word failed back surgery. No one likes that. The surgeons don't like it. The patients don't like it. Nobody wants to know if they had a failed back anything. So how is it that you work with those other disciplines to help the patients?
Sure. I think of pain management kind of as an intermediate step between more conservative therapy, medications, physical therapy, acupuncture, chiropractor, and between that versus surgery. So it's less invasive compared to surgery. So I would advise patients to try pain management, try these epidural shots, nerve blocks, other types of therapies that a pain management specialist could offer prior to going into surgery. Sometimes what we do are maybe just enough to keep them from surgery.
So you would recommend the procedures that we were discussing maybe prior to surgery. And I agree, just from my experience, I would always recommend a patient, if it's absolutely the best route for them, is to try and avoid more invasive procedures, do less invasive. And then if we can't help the condition and surgery is ultimately the end result, then you work with that surgeon and you give them the history and you help them as best that you can. So it's a tough decision for the patient sometimes because they get conflicting information. And now you also do some minimally surgical procedures. There's something called kyphoplasty that again, people may not be aware of, but it's kind of for a specific condition we talked about disc herniations, we talked about stenosis, arthritis of the spine, which would be like a facet issue or degenerative disc problem, and all of those things could work with different procedures that we spoke about. But kyphoplasty is a little bit more specific. When would you use something like that? And tell us what that is a little bit. Sure.
So it's a procedure we perform to actually restore vertebral body height in the spine from compression fracture. So the spine, just like it's made of bones, just like other areas of the body, it could be prone to breakage and so forth. So especially in patients that has osteoporosis, where the bone is not so dense, it's actually soft and pretty brittle. So
that's common to a lot of people with osteoporosis, or if they have a trauma. Sometimes even instantaneous combustion of the vertebrae, a hard sneeze sometimes can do it, right?
They could be just bending, picking up something, and all of a sudden they will have acute back pain. And many times they're not diagnosed because often they're just saying, oh, you got back sprain and so forth, and the patient is just sent away with just some anti-inflammatory, maybe some bed rest, physical therapy. So number one, I do think it's underdiagnosed. And number two, when it is diagnosed, a lot of doctors actually don't know this procedure is available to treat the pain.
I agree with the underdiagnosed part, because sometimes it's hard to tell if it's old or new, and I think this is something that maybe you want to know how current. So the history is important. Was this a recent trauma? Did this happen recently? Did the pain come on suddenly? Did you fall? Did you slip? Because if you look at an X-ray and you see a compression, and if it's old, it's not maybe the results. You want to try and catch this early, I would guess.
Correct. The results are best for kyphoplasty if it's done in the first 3 to 6 months or so.
3 to 6 months.
6 months. It's not saying, patient with compression fracture can't get it beyond 6 months. There are times where the fracture already happened, patients still have pain. The fracture could continue to have more fracture. Just because it fractured once doesn't mean it can't fracture again. So in those situations, the patient could get kyphoplasty if it's indicated. The chronicity of the procedure or the fracture, we could tell from certain things. You mentioned about the history. Patients said they slip and fall, they have pain. That's obviously a good indication that could be the start of compression fracture. Other ways, CAT scan, MRI, bone bone scan often will show signs of acute inflammation that could also assist us in terms of determining the age of the vertebra.
You could pick up certain activity on the scans to see how old that is. Okay.
Right.
Well, I think it'd be interesting. We're going to show another little video here just to get a sense of what that looks like. So let's talk about this procedure, because I find this one very interesting, the way that you get into the vertebral body here.
Okay, so here we have a picture of the vertebral body, and then someone with osteoporosis will have very thin bone there. And here's actually what happens with the compression fracture. Patient end up losing height as well as having pain.
Now, what's going on here? Is something being injected into that vertebrae?
Right. So through the skin, we enter with a trocar, which is a larger size needle. And this is all done with no incision through the back under X-ray guidance.
Okay, so it's under fluoroscopy again, just like an epidural.
Right.
Okay, so that comes in handy, that fluoroscope, right? You use that a lot in your office. Okay.
Yes, it's an expensive tool, but well worth it.
Well worth it, right.
It certainly helped with the precision of the injections. So after we insert the trocar, through the trocar we actually insert balloons, and usually we enter with two sides.
Okay.
The balloon gets inflated.
So there's two needles?
Right, one on each side.
One on each side, okay. So the video is showing one, but it's two, okay.
Right. So inflate the balloon, that'll help restore some of the height of the compression fracture, and it also creates a void. The void that's created, we inject bone cement and fill it to basically solidify.
There's an actual balloon, you blow it up, almost, I wouldn't say similar to an angioplasty type of, but similar, trying to create space.
Space, right.
And then basically you're going to fill that with some kind of biologics of cement or some kind like that. Okay. Right. All right. So that's and then it just stays like that, or now do you have to worry about compression in that area again, or?
Yeah, a patient who has compression fracture, right?
Solid.
That area is that area is pretty good. It's just solid. Okay. It's hard to break
Sometimes
that area.
The area above and below you have to worry about.
Right. If a patient has a history of compression fracture, there's a good chance they have osteoporosis. So other areas, there's a good chance that they could fracture those in the future too. And the importance of this procedure, obviously, the short term we're looking for pain relief, restore function, but left untreated, though, the vertebral compression fracture, patients are often end up walking bent forward.
More like a kyphosis or a rounded back.
And that could put stress on your vertebral body level above and below, causing more fracture.
More compressions, right.
In addition, when they're walking hunched over, that also restricts their lung as well as their heart. So if a patient already have poor cardiovascular or pulmonary status, that could even make those areas
putting more stress on the body.
Right. They're not able to expand the lung. So, left untreated, the patient could go into pretty bad.
It seems like almost a domino effect. One vertebrae above the other, and then if you don't treat the one that's really supporting in between the two, everything kind of can collapse down on that. So.
And they show the actual mortality and morbidity rates of vertebral compression fracture as high or even higher than patient with hip fractures.
Oh, okay. So and we know those are pretty significant. People, for a while, I think it was, not that we're talking about hips tonight, but I think it was like post 5 years after a fracture. That was at the time. That was like the average life after. But nowadays, I think that's gotten a little bit better. So. Look, your specialty is very, very intriguing. Very interesting. I hope our viewers have gotten some education on what can be done, not only to help them, but also they don't have to go into a hospital setting. This can all be done in a outpatient, comfortable environment, in a controlled, ambulatory surgical room that you work with your colleagues and your nurses and feel safe. I know there was a little bit of a scare for a while about some of the medications and the epidurals, and unfortunately this happens in medicine. Tainted drugs, and it's not anyone's fault, the manufacturer maybe, but the doctor, but so patients get maybe a little scared. Should patients be concerned about these procedures? Are there a lot of side effects like any other procedure?
There are certainly side effects, and I discuss and disclose all the possibilities with the patient. They are rare, and they do include headache, bleeding, infection, nerve injury. hardly ever have to send a patient to a hospital because of something like that. So it is extremely rare, and it's an outpatient procedure, like you said.
And the fluoroscope helps.
Oh yeah.
Back to the fluoroscope.
Right,
it's your eyes, it's your eagle eyes, so you know what's going on and where everything, where the needles are, and understand the condition.
We also have an ultrasound machine, so we could use ultrasound, and with that we could see the needle. We could actually see the nerve that we're trying to inject and block. So adding another part of safety or precision to the procedure.
And most of these procedures, the patients have to be under anesthesia, or?
It depends. And if the patient's anxious, we could certainly offer that. And not, most patients, I would say they don't need the anesthesia. The procedure is done just under local anesthetic. A little bit of lidocaine at the skin or numb up the skin will allow us to insert the needle. Some patients, unfortunately, are anxious before a procedure, so we could offer the sedation, and they're comfortable. Other procedures that are a little more invasive could be painful at times, so we do suggest sedation for those kind of procedures.
Okay. Now, I'm going to ask you a question. I don't know if you see this a lot, but it's something I've always had interest in, is reflex sympathetic dystrophy. And it's one of those tricky diagnoses and tricky, I just wanted to know if you had an opinion on that, or is there anything that you work with any patients, or is it something where maybe neurologists tend to treat that a little bit more? Right.
I see my fair amount of patients with RSD, or commonly known actually now as CRPS, complex regional pain syndrome. They're rare out there. I'm happy because it could be a very tough condition for the patient. And it's a neuropathy where a patient could be very, very debilitated. They could have swollen hands, swollen legs, and the neuropathy could actually spread. Yeah. So it could start in one limb and it'll migrate to a different limb and eventually cover all 4 limbs. The importance is really catching patient with this diagnosis early, and unfortunately though it's not an easy diagnosis to make, because
it's difficult. I know
most people don't know what it is.
Again, the history is so important, as we know as professionals, just knowing how the patient got to you. If they had a surgery, sometimes it can occur during a surgery, and there's other ways that the diagnosis can be picked up early, and that's the trick with anything. And so we discussed a lot of different things, epidurals, neurostimulators, kyphoplasty, a little bit of RSD. What's the one thing that you would tell our audience in terms of your specialty? When should they seek you? Should they be seeing their primary care doctors, their specialists first, and then before, or you want to see them from the minute the pain starts? Or is it? Just depends.
I think it really depends. I would think most patients would probably seek their primary care physician first. Try the anti-inflammatories, try the oral steroids, maybe do some physical therapy. If the pain's not really well controlled that way, then I think it's time to see a pain specialist.
Right. Okay. Well, we recognize that pain is a very costly, very traumatic, very difficult thing for the population. I think the industry in totality is $500 billion in total expenditures in hospitals and medications and treatments and lost wages. So we need specialists like you, so we're happy to have you. We're happy to have you as our guest today.
Thank you.
I want to thank everyone for watching Health IQ, and hope we've taught you something important today. So thank you very much, Doctor.
Thank you, Dr. Segal. Thank you.